When I'm standing up here and Dr. Ford is next to me, she was with me when I placed my first Foley, started my first IV, both unsuccessful. So there is hope for everyone. No, thank you for that introduction. I don't deserve it. It's the people around me that deserve the credit, and the people like Joshua, who gave that really interesting, research on duck and goose stuff in the water. That is the real. That's the real test. And Elaine, who's going to speak after me, these are the people that really make the difference. I think my role is unique in that I can mentor others and inspire them and encourage them, and that's all people need. Can I just kind of ask a question, though? You in the audience, how many are nurses? Oh, good, because that's what this is about. Because if you were cell biologists, it probably would not have the same impact. So how many of you are getting your bachelor's? Okay, and then the rest are master's prepared nurses. Well, that's exciting. That gives me a lot of hope for the future, and a lot of you are employed in the facility where I work. Now let me see if I can work our technology here. Okay, what I want to say to you revolves around three things that I've learned through my educational preparation here at LCU. The work of leaders is change. Always. It's how we flex or not flex or adapt to this change that really makes a difference in our healthcare organizations. We want to make things better for patients because look around, we're going to be patients. And our grandchildren may be patients, our brothers, our sisters, our husbands, our wives. That's what's important, that we do the best by these patients we serve. And we want to always seek out the best clinical evidence that is out there to care for patients. That's what's important. It's the best way to continuously search and seek out those practices that make an impact in our community, in our workplace. Healthcare in this century demands it, and we have to deliver that. Transformational leaders, that's you in this room. That's not me, that's you. You guys can make such an impact in your organizations. It requires very innovative environments. Innovation is one of the most important things that we can bring to our hospitals and in our care settings. Innovation and an ability to not say no, say yes, we can. To say, I have a question about this practice. I want to know more about it. That's how change happens in hospitals, and we have to nurture that. Our intent as nurse leaders, and that's you, is not just to fix a broken healthcare system. It is not just to solve problems. It's not only to empower our staff. It's to innovate and be proponents of change and asking those questions at the bedside. I like this quote. I think it's pretty, I don't think you guys can see it too well back there. If your actions inspire others to dream more, learn more, do more, and become more, you are a leader. Again, that's all of you sitting here in front of me. We have to empower our staff in hospitals. We have to develop, direct, and guide them in this practice. We have to continually question what we're doing. This is probably the most important competency of any nurse, questioning. Through evidence-based practice, staff are empowered to change their practice based on science. It increases autonomy of practice and professionalism. That's part of the journey. We all know that those patients in our hospital settings that receive evidence-based care have 28% better outcomes. So why aren't we doing it? Why aren't we making that challenge to our coworkers to ask questions. I'm the I in inspire. That's the message here. That's my duty. I'm here to inspire others, to encourage them. All of our bedside leaders, and that's what I call our staff at the bedside, they can make a major impact on the quality of nursing care because they have this special relationship with that patient and those families. You have to be very optimistic that it can be done. You have to use some influence and some creativity to get that job done. You have to paint a vision that evidence-based practice and adoption of that is a process that can be learned and used by every nurse in your hospital. Leadership and guidance are key to understanding evidence-based practice and to enable our nurses to employ those best practices at the bedside to better our patient outcomes. If you can imagine it, you can achieve it. If you can dream it, then you can become it. I think since so many of you are working on your masters, you probably already know the 5 steps of evidence-based practice. Raise your hand if you know these steps. Because I remember Dr. Long, and does anyone want to come up here and explain this slide then? Yeah, well, so we break it down into these 5 steps. We frame a question and we formulate the burning clinical question that we have about our practice. And then we help guide these nurses to search for the best evidence. And they have to have the resources available to do that. There's electronic databases, Medline, Cinol. I know you're intimately involved with those right now. And critical appraisal of the evidence is the 3rd step. Can you generalize those findings from your lit review to your patient population? A lot of times the literature in pediatrics is not so huge, and we use adult studies to figure out what we're going to do with our pediatric patients. That kind of gives you an idea of that. Then we integrate the evidence into our daily practice. And then we look to see if it's effective and if it works. There are barriers to accomplishing this, though. We know that in our hospital settings, many barriers. You know, nurses are so busy right now. They have so many patients. You know, they don't have time or resources to figure out what evidence-based practices are out there that would benefit them. Sometimes our organizations are not structured to empower them. Sometimes our own leaders don't keep this as their tenet when they perform their daily duties, which it really should be. Some of our leaders do not have the educational preparation to understand the significance of working this way. So we have to change that. And again, I'm so hopeful seeing all of you out here and knowing what an impact you're going to make on our patients, because that's the most important thing. I just have a few examples of some of the things we've done at the Children's Hospital. A very strong team of nurses, very interested in what's the best thing to do and what is out there that's new, what we can apply to our patients. And they've really made a profound impact on care. Of course, rapid response teams are old news. That's nothing new, but we took it a step further than that. We have pediatric rover teams based in our ICU that actually go to the pediatric floor, pediatric med-surg floor. Kelly and Ramona, you guys know about this, and have a conversation with the charge nurse about 2 times a day about patients that she may be concerned about or that are problematic or the vital signs may be questionable, and they can, you know, base what they're going to do next that's in the best interest of that patient. And that's kind of a novel idea. Family presence during resuscitation and invasive procedures. You would think that just makes sense, that families be included in the things that happen to their children, but it's still a struggle in big healthcare organizations to apply that to the adult population. We have a lot of pushback sometimes from our peers and our physician colleagues. Family activation of rapid response teams. That's where the family member picks up the phone and activates the rapid response team. That's a little bit new in our setting. All of those things together make the patient safer. And we all know that we need to make our patients safer in the hospital setting. The last code that we had on the pediatric floor, Ramona and Kelly, was in May of 2009. So you've seen about 7,800 more patients since then, and that's how good you're doing with that. That's very significant. PEWS, Pediatric Early Warning Scoring Systems, those are in place to give a trigger to the clinician when a patient may be deteriorating and may need to be transferred to a higher level of care. Medication safety zone, we did that in the PICU recently to give a nurse a quiet timeout place where no one would interfere with medication delivery, because we know that is a very error-prone operation in the hospital. So we've done that, and that's affected a lot of patients positively. PICU simulation project. One of our nurses was involved with Randall Stinnett at the Covenant School of Nursing, and they did a project where they would assess the competency of nurses at the bedside using simulation, and that was pretty neat. So really, to get these types of initiatives going, the key is to give people information, inspire them, be enthusiastic about what is going on or could happen, and tell a story. That's really effective. Telling a story of a patient that had a bad outcome or perhaps had a great outcome because of one of the initiatives you started, that generates excitement, and that excitement is catching. So nothing great was ever achieved without enthusiasm. Again, you just have to encourage the risk-taking on the part of your staff. Encourage them to go out there and try something new. Create excitement, and bring all of that resistance to change out in the open where you can deal with it in a positive manner. Because there is a lot of resistance to any new thing, any new change. Ramona, that's a picture of you. I thought you might be here. That's a picture of Ramona and an ICU charge nurse doing their rover rounds with a pediatric patient. That was my personal project when I worked on my Doctor of Nursing practice, and it turned out to be quite a nice project. The patients that the rover nurse transferred to the pediatric intensive care unit, we looked at 3 different groups. We looked at physician transfers, rapid response team transfers, and the rover team transfers. And all those patients that ended up in the ICU that the rover team nurse transferred, the majority of those patients had to be intubated and ended up on ventilators for, a greater length of stay than the other 2 groups. Actually, the ones who bounced back to the floor were the ones that the physicians transferred. So it gives you an idea of how nurses can really impact the patient experience. Their eyes and their critical, appraisal of patients is so important. And there's a picture of Shannon. She was a graduate from the master's program here, I think, a year ago. 2 years ago, Dr. Ford, I'm not sure, and that's Randall Stinnett. And again, that was just to assess competency of nurses using simulation in clinical settings. Very proud of her. She's done some great things. She's in another picture. This is Shannon and Rachel, another graduate of the LCU Masters in Nursing program. That's the Condition H project, Condition Help, Family Activation of Rapid Response. So that was a poster that they presented at a Texas conference for children's hospitals. There's Megan Oldham and Tara Nagel, both from the PDICU also. There's their poster, Safe Zone for Medication Safety in the PICU. All they needed was a little push, a little shove, and look what happened. So definitely, in my experience, and since this is what I'm giving you as my experience, culture change is needed at all levels in a large organization. needs to be one that thinks that evidence-based practice leads to optimal patient outcomes. And I think we're really headed that way. There is work to do yet. I don't want to say it's all perfect. Developing and encouraging our physician colleagues to partner with us in evidence-based practice, that was probably one of the most astounding things for me, is that physicians don't always have the time to read, you know, their peer-reviewed journals or know what's out there, and we play such an important part because we can get that information and head it their way. Imagine if you have over 100 pediatric patients coming to your clinic every day. Do you really have time to sit down at your computer? And then you have to go to the hospital and see your patients in the hospital. It is astounding how little time they do have. So it becomes our responsibility to partner with our physicians and help them and let them know what's out there. Understand that it takes time to have a change in culture. You know, Covenant Health System, where I work, you know, we have a large proportion of diploma RNs employed there, and that's not something, evidence-based practice and research is not something that they're familiar with from their educational preparation. So, you know, we have to educate them and help them understand why we do what we do. It usually takes 3 to 5 years to appreciate a really good change in the culture of an organization as far as this goes. So I think I'm about 14 months in, so I'll report back to you in 5 years. I would encourage all of you, this has been my experience. You read a great article, you want to know more about it, you look at the authors, you see where they're based, you know, where they work, and say, hey, I'm going to contact them and ask them a question. You know, that's how I started my project for my Rover team. I called up this nurse practitioner on the left of the screen, Remy. She is a critical care nurse practitioner at Duke Children's Hospital, and she's a great colleague, expert advisor, friend, and I can always get some information, and she has actually asked me for information and policies. So it's synergistic, this relationship, and I would encourage all of you, if you have an interest in something, to call the author, to write them, send them an email. It's very rewarding, and you have these relationships that span time and distance, and it's really wonderful and helps in our organizations to have those relationships. The picture on the right is with some faculty at Texas Tech University, Department of Psychology and Nursing. We're partnering with them on a Department of Defense challenge grant for some medical technology for medication administration, and that's been a really nice relationship. That helps us all grow and experience the part of research that we may not experience in our own organization. So that expertise is very well received. So find what intrigues you again and reach out. Remember that everything is possible if you challenge and you question and you really say, hey, that status quo, those sacred cows that are out there, they really need to go. I think we can do it a better way. The key to mentoring and fostering a evidence-based practice climate in a hospital is being able to educate those nurses at the bedside, and that is really tough. That is really tough. You guys probably can understand. Like I said, some of the nurses that we have in our surroundings do not really know what research is, or, you know, is there a difference between research and quality improvement and, you know, things like that. So we have to have a vital role and help them understand and educate, and all of you will fulfill that role quite nicely. I can see that happening. They need to know how to ask questions and where to find answers and how to translate that to care at the bedside. So leaders are asked to encourage these nurses to ask the what and why of clinical practice. If you don't remember anything else, just remember to go forward and get your staff and the people around you to ask those two questions. What are we doing and why are we doing that? It's pretty profound. So that kind of climate really supports the flowering of evidence-based practice in an organization. I just put this slide in here. This is of a colleague of mine in the PICU. There's a little bit of confusion about what is research and what is quality improvement, and you have to have a little bit of a grasp of that. I see often in my setting that everybody calls everything research. Oh, it's research, when in fact it's not. It's a quality improvement project. So you really need to know the difference, going forward, and that's my role, is to educate and help people understand that. They're similar. Both ask very clinically important questions and sometimes use patient data and analyses to come up with answers. But really, I think the difference is, if you're doing something to a patient, what kind of risk is involved. That helps you understand and differentiate between quality improvement and research. So I like to think that we are changing practice one clinical question at a time. If you can get staff and your colleagues to ask the important question, and remember that not mentoring these folks is one of the biggest barriers into implementing research that's out there into practice at the bedside. And you guys know, you master's nurses, how long does it take for research to actually reach the bedside in practice? Do you have an idea? Give me a number. Yeah, Elaine's well aware. It can be anywhere, I like to say 1 to 2 decades, because that sounds so much more ominous. 1 to 2 decades, that's terrible. If it's your family member or your child, do you want us to be doing something that is outdated, antiquated, when there's some better evidence out there? So as nurses, that's our job, is to move that a little quicker along so we can give the best care to our patients. I think something that's very important for nurses at the bedside is to be able to get real-time answers to their questions. And we struggle with that even now. And again, when I report back in 5 years, I hope to have accomplished that problem completely. And then as leaders, you're an active learner, all of you. Today you are you. That is truer than true. There's no one alive who is youer than you. And this is my favorite author, Dr. Seuss. The more that you read, the more things you will know. The more that you learn, the more places you'll go. So the emphasis is on taking action, thinking, and always learning. So in closing, if you have any questions, I would love to entertain them, as long as they're not about the PONS or diabetes, because I don't know anything about those things. But I think, like this quote says, the important thing is not where we are right now in nursing or in healthcare, but it's where we're going and where we're headed. And I just want to thank all of you for continuing your education. It's so important, and I see so many of you out there that I know, and I'm so proud and happy that you're here and you're learning and you're going to start asking those questions and helping others around you ask those questions. All right, can I answer any questions?
I hope it's kind of related. You're talking about research and evidence-based, bringing that into practice in your work. And we're seeing an increase in importance of nursing in all of this healthcare debate. So where do you see a little bit of that going in the next couple of years in terms of your profession, in a more global sense, not just in research, but in terms of just your profession itself?
Well, that's interesting. Probably the nursing folks in the room have heard of the the Robert Wood Johnson and Institute of Medicine's report on the future of nursing? You probably have not, because you're not a nurse. But in healthcare organizations, this report came out, and it spoke to the value of RNs being able to practice to the full extent of their education. And that is one of those things that helps translate what's out there to the bedside. I do see healthcare is moving so rapidly with technology. I think things are going to get better. But then we have all this going on with, our changes that are coming up with, potential of all these uninsured coming into our system. It's overwhelming. I mean, we're looking at, in the state of Texas, almost 16 million more children being added to the Medicaid rolls in the year 14. So we don't have enough nurses. We don't have enough practitioners to care for all these folks. So it puts a lot of stress on the system, and it's already kind of a limping along system. I don't know if that's answering your question or just making another question.
Well, the point is your profession's becoming more important in the whole healthcare picture because doctors are harder to produce and harder to maintain. And so this mid-level provider seems to be more the key answer to the problem than anything else we have.
It is, and we're looking at, such different models of care delivery now. Medical homes and accountable care organizations and nurse practitioners are going to play such a vital role. How that's really going to look, there's a lot of restrictions to, advanced practice nurses practicing in the state of Texas. So we have some hurdles. We do have some hurdles. Anyone else want to comment on that? Any other questions? Okay, then I'm almost done.
Talk a little bit about mentoring. Is there an established mentoring practice in most hospitals? Do novices work with mentors on a formal basis, or is it more informal mentorship?
We have both formal and informal, but when you look at mentoring evidence-based practices, that's a whole other skill set. There's so few advanced practice RNs in our setting. They're not utilized as they might be in a teaching facility. So it's a big hurdle. It is a big hurdle. And it's something that probably Susan Sayari will be helping me with here in a few months. Yeah, but we have formal and informal ways of mentoring. But again, this is just another, thing we have to mentor on and educate on. And Elaine will be one of those too. She's very important in our hospital just by the work she's done. All right, exciting stuff. Thank you.